A very warm welcome to all. I'm Mahindra Mehra, MD of Soniscape Medical South Asia. On behalf of entire team of Soniscape, I thank each one of you for being partner to initiative of continued ultrasound learning and education from Soniscape, especially with immense support and guidance of most of the senior key luminaries and prominent teachers of the field across the country. We have large number of attendees already joined in, and I see several doctors still logging in. So I take this opportunity to take you through a few slides. Soniscape has taken a big leap in ultrasound industry by incorporating most advanced and innovative level of artificial intelligence, AI, into our premium range of color Dopplers with deep learning algorithm. Here, it is important to highlight that it is not just some auto measurement like presently being offered in the market, but the Soniscape premium color Dopplers with latest architecture and AI-based platform offer full automation and simplification of scans for the users, along with high diagnostic confidence, especially for wide range of shared service ultrasound applications using machine learning and deep learning. The built-in deep learning algorithm mimics the function of human brain and are capable of learning and evolving with assimilation of big data through machine learning via lakhs and lakhs of referral images. The technological advanced hardware platform of Soniscape color Dopplers also facilitate faster scans, that is shorter scan time, I think, which is highly beneficial, and all of us will agree, especially during these challenging time of COVID-19, the faster scan and shorter scan time provided by Soniscape color Dopplers are of high importance. Soniscape's premium Dopplers enable auto acquisition and auto identification of scan planes and anatomical structures. It also facilitates auto outlining of areas of interest, borders, and its characteristics, along with auto annotate and auto measure. Now talking about breast AI, it automatically outlines suspicious lesion borders and reports classifications according to the BI-RADS standards. Also, it provides standard reporting on classification and benign and malignant masses. Similarly, S-Thyroid AI of Soniscape, it's a very advanced tool which auto-detects and classifies suspicious thyroid lesions based on PI-RADS along with auto-reporting. Especially this S-Fetus, the obstetrics AI of Soniscape high-end color Dopplers, is fully automated, and it accurately identifies significant planes and fetal biometry based on deep learning and big data. So we see Soniscape provides most in-depth and widest color coverage of artificial intelligence for shared service, multiple applications in the entire industry. So, and then we see obviously highlighting all the high-end premium features which are available in the industry are obviously there in the Soniscape high-end machines. I'll take you through a few of the high-resolution clinical images for wide applications. And yes, especially talking about obstetric scan, which is the topic today, Soniscape high-end color Doppler have all the latest technological features. Few of the 3D, 4D images I'm sharing here. And now again, I'm trying to repeat this automation, which is there available with Soniscape machines, is the need of the hour, especially in these challenging times of coronavirus, because in every aspect and every operating mode we are with the Soniscape models, we have automation, we have automatic features available, which ensures that our scan time is nearly half or even lesser time we take for completing each scan. And just to show you the widest range of color Dopplers, I think one of the widest range of color Dopplers in the industry, both in standalone and portable model. So just to remind, you can enter your questions onto the comment box available on your screen. So now I proudly welcome our eminent, well-known speaker and guru, Dr. Ashok Khurana sir, who has been an inspiration for most of us for years. Dr. Khurana has exceptional expertise and interest in obs and gynae, and he has been the past president of the Society of Fetal Medicine. Dr. Khurana, as we are aware, has authored numerous books, clinical papers, articles, and publications in various national and international journals. He has been an outstanding faculty and speaker in several conferences, CMEs, workshops, world congresses, and events, both in India and also globally. Thanks again, Dr. Khurana sir, for your continued support to Sonoscape all these years, and also taking out time today for this webinar session. So now I hand it over to you, sir. Thank you very much.
Thank you. Thank you very much, Mahendra and Gaurav, and my thanks to your company Sonoscape. And I'm so pleased to be here to share a topic with my colleagues today. And I'm going to discuss ultrasound of the human embryo from 7 to 10 weeks and show you how we've truly caught up with what was the artist's imagination, and yet given it such a sensible clinical bias that we wonder how we could ever do without this. I look forward to about 45 to 50 minutes of a formal presentation, and then of course questions are always welcome. And I want to start with my cover image of this, of what Leonardo da Vinci did long ago. As you know, it's been several years since he's been gone, and he was one of the great men of the Renaissance in Italy. And today, the kind of technology we have lets us reproduce this not with a paintbrush or a sketch pen, but with technology that gives us truly what is happening inside the uterus, and therefore what is happening with the fetus, to the extent that we look not only at the surface like Leonardo had imagined, but actually within to get information. And of course, side by side, we understand that it's not just high technology that we're looking at when we look at the embryo. We do look at the original low-end technology as well, because these two will go hand in hand. So we always have the beginning, as I see in this window here, and then we have the...
Sorry to interrupt. We're waiting to share your screen, sir.
Oh, my screen is not yet shared, and my apologies. It is shared, but I will again make sure. Okay.
Yes, sir. Now it's visible.
Wonderful. My apologies for this, and I'm so glad you interrupted me for that, because this is what I was showing, and that was here to let people know that even here we combine the latest technology with the most original technology of standard grayscale 2D ultrasound, but we go beyond so that we can give images not of an artist's impression like Leonardo da Vinci did this a few years ago, but like this, which is real-time live reconstruction. And technology today takes me beyond, not just on the surface of the embryo, but into the embryo as well, to be able to give me clinically relevant information. So I will move on to then not give you, should I say, a show-off or showcase of sonoembryology. No, I will take you through everything, which is the components of an optimal examination prior to 11 weeks of pregnancy, the protocols and guidelines that are available for this. I will take you through normal embryonic development and pattern recognition, and of course, the disordered development that can be seen thereof and the ultrasound features of this disordered development, with the idea of letting you know the clinical implications of ultrasound findings, because after all, there is no point in having images when they don't have a clinical implication. We're not here to make beautiful images. We are here to go beyond that. And I would like to admit here and announce that there was so much about this period of gestation, the 8 to 10 week period, a time before the classical 11 to 14 weeks of when we really start looking seriously at embryonic morphology or fetal morphology. At the World Congress of the International Society for Ultrasound and Obstetrics and Gynecology last year in Berlin in October, And the work that was presented there by two doyens of ultrasound and the leaders of ultrasound truly inspired me to put this talk together so that I could inspire my own colleagues to actually start looking at this period differently. And the two talks that we really heard and moved us were Fetal Malformations in the 8 to 10 weeks era, The Dawn of a New Era by Simon Meagher, and The Amazing Embryo in 3D by Bernard Benoit. And you know how great these people are at their work, and they truly gave us a unique insight on how we can apply technology to start thinking differently and to benefit our patients a whole lot compared to what we thought. A lot of what they have said is also summarized in this article, and you know I love to give references so that you can read this at leisure. And this is a representative image from that paper. And this is in the May issue of the Ultrasound in Obstetrics and Gynecology, you know, the white journal of ISWOG. And it's an opinion right there on the first page of the May issue. And it talks all about what I'm going to be saying. So for those of you who want to go back to the theoretical aspects, as well as learn some of the practical aspects, do read this paper. It's not a free download as yet, but it's accessible and you will benefit a lot. One more paper that has greatly inspired me over the years, but seems to have been lost in time, is a paper that came out in 2014, again in the White Journal. And this was a group which was supervised by Borel. And what they mentioned in that paper was that they actually found that the nuchal translucency was a useful aneuploidies marker even before the 45 to 84 millimeter window that we classically look at. What was this window? It's a 28 to 44 millimeter window, which means from about 9 weeks to about 11 weeks. And therefore, a lot was actually happening for several years, but it seems to have been lost. What was the most important, of course, was that a thick nuchal translucency was described by them in the entire 3 Down syndrome babies they had in that cohort. They were able to identify a large number of the trisomy 18 and 13, and therefore it seemed to be a very, very good idea to actually start thinking of this. And they gave this absolutely marvelous chart, which said that at 28 millimeters, there was a 5th and 95th percentile, which they had calculated for the NT, the nuchal translucency, and that they had data that we can follow here. A lot of my colleagues today say we do find it, and a lot of us are told it's not relevant, just reassess it at 11 weeks. The fact is that today, when we do find edema at the back of the neck from 8 or 9 weeks onwards, we need to look at it differently, because we can guide our patients differently and we can get them to benefit in a much more sensible fashion. And that is what we will discuss today. Not just nuchal translucency, but beyond that, to actually look at the embryo and get things worked out the way we like to work these things out. And therefore, I will talk an introductory set of slides on the first trimester scan and the perspective, because this is not a routinely practiced scan in most parts of the world. However, it's commonly practiced in developing countries because very often it might be the only ultrasound scan that our patients have, because our patients often have access restrictions. They may never see a doctor again. So it might be just a very good idea to date this pregnancy, because this patient may never, ever, ever either get to even see a doctor again, far less have an ultrasound again. When the patient is symptomatic, that is, they have pain or bleeding, then it's indispensable to have this scan to triage those that are going to have a good pregnancy, or those that have a failed pregnancy, and those that need support or further investigation of pregnancy. And therefore, it's useful. Also, in patients who have a possibility of an extrauterine pregnancy, then of course, you would like to make sure that yes, it is not extrauterine and it's intrauterine, and then whether they need pharmacological support or not. And then of course, there would be those that on clinical examination or a vaginal examination would have a palpable adnexal mass or a uterine size not appropriate for dates. And again, these patients will need special inputs, and therefore the early first trimester scan really has a lot of applications. Although if you go into protocols from the West, it's not really used there. Also because scanning is relatively expensive and we need qualified personnel to do this early scan. Also that the view is far better with a transvaginal scan. It's sometimes skipped. But when it's done correctly, it offers a wealth of information because it's very useful when patients have a history of miscarriage or they're infertile patients where we want to confirm an intrauterine pregnancy, the size of the pregnancy, and of course, if they have any other significant known risk factors. Sometimes it can be used for maternal anxiety, and this is perfectly justified because we don't want an anxious patient for the first 3 months of pregnancy. We don't want an anxious patient anytime, and this would help a lot. It's routinely used in high resource settings because of the kind of information that I was telling you about. And therefore there, of course, we don't have cost considerations and it yields a lot of information. In the future, this might be done routinely as a scan for medical legal considerations because the environment of the doctor-patient relationship is now so strange in most parts of the world, including our part of the world. We are perhaps the worst when it comes to even skipping legal action and moving straight on to violence. And therefore, it might be a good idea to actually do this scan for just about everybody so that we have a documentation that there's an intrauterine single live embryo, so to say. The actual protocol that we need to do is to confirm that there's an intrauterine pregnancy. And even if you confirm an intrauterine pregnancy, you must confirm that there is no extrauterine pregnancy. You never know which patient had an IVF. They don't necessarily tell us the truth. You never know which patient actually took ovulation induction drugs because they might have been given by a pharmacist or just a local health worker, a dye, and so on. It is then used to date a pregnancy where we do dating and therefore estimation of gestation age at that time and extrapolate it to a estimated date of delivery. We need to confirm the number of sacs, the number of fetuses, and how many of them have heartbeats. Then we assess the chorionicity and amnionicity in multiples. We assess fetal morphology and deviations from norm. And this truly is what my talk today is going to be. And therein lies the difference. We're not just going to say, okay, single sac, single fetus, yolk sac, heartbeat, and crown rump length, end of story. No, we're going to look at the morphology of the embryo because there is a wealth of information that can guide us usefully, and we will discuss that. We will, of course, anyway look at pathology in the mother, such as in the uterus, the adnex, or anything else in the pelvis. And then, of course, it's used for a lot of procedures that are done in gynecology and obstetrics in the first trimester. The reason why we're doing this from the point of view that I had stated, which is embryonic morphology, is that an early pattern recognition of abnormal structure facilitates early diagnosis. And therefore, it's one of those situations where we have no option but a very poor outcome and not even the possibility of a delivery at term because of the possibility of a miscarriage or a intrauterine fetal demise. Then a safer and easy termination of pregnancy is possible at this window. In fact, the 8 to 10 week termination, as you know, is far safer than the 11 to 14 week termination. There is, of course, also the need to understand the limitations of doing scans at a period of gestation that is too early. And this scan does not replace the 11 to 14 week scan, and it certainly does not replace the anomaly scan between 18 and 22 weeks. So those will stay where they are. This will facilitate a different kind of decision making in this particular situation. Counseling is very important, and so are genetic investigations. And we end up hurrying these decisions if we see them, say, at 18 or 19 weeks and we see a problem there. Also, in case we have to investigate the parents and then we have to investigate a sibling or the index case or the proband, as we like to call it, then we need time. And therefore, the sooner we make a diagnosis or the possibility of a diagnosis, the better it is. And therefore, it's useful to actually look differently today at the 8 to 10 weeks window. And then, of course, if there's bad news, the patient might want a few more days to get used to the idea of their loss. And this gives them plenty of time to get over it, to share their grief, to take decisions after second or third opinions in case they're not happy with one, or just to generally make them feel good that, yes, I did everything that was possible. After all, the loss of an embryo is pretty much equal to the loss of a child for most people. Now, the first slide always that I like to show when I talk about the 8 to 10 weeks window is that ultrasound is safe for the embryo, and it is safe even at this window. That transvaginal scanning is safe and color flow mapping are also safe, but fetal spectral Doppler that I see occasionally in some people's reports for recording the heartbeat and making the patient hear it has not been proven safe at this window before 10 weeks. And therefore, I strongly recommend that for heart rate calculation, we should use the M mode and not Doppler to display and record the heart rate. Remember that we always still use the ALARA principle, which is as low as reasonably achievable. That means you won't go on scanning on and on to get a beautiful image just to show that, yes, there is an umbilical cord like this. Certainly not. This has no clinical information. But technically speaking, it does. We know that the cord length is good, and if it's good at 9 weeks, it's likely to be good at term. But that's not the kind of information we're specifically looking at, even though color flow mapping is safe. What I mean to say is that no actual spectral sampling of a waveform within the fetus, and everything else, of course, color flow mapping is safe, but always do it for the shortest period of time that gives you the answer to the clinical question. Now, there are a lot of groups that I have come together to a consensus to first put the first problem out of the window, which is before the 8-week criterion. And that is that this question of is a fetus viable or not? And for several years now, all the groups have agreed that the reading for a mean sac diameter should be more than 25 millimeters rather than the old reading of 20. And if that has no fetal pole, then that's an anembryonic pregnancy. If we have a crown rump length of greater than or equal to 7 millimeters rather than 6 millimeters, which was our previous standard, and it has not got a heartbeat, then that's for the diagnosis of a miscarriage. And guidelines also very clearly state that a transvaginal examination should be performed in all cases, and that serial scans are encouraged. So if there's any element of doubt, there is no harm in calling the patient back after 2 weeks or 1 week, depending on the clinical situation and how much the patient can tolerate her anxiety, to confirm what is going on, and never to be in a hurry to declare a fetus is non-viable. Now, some vocabulary that needs clarification so that all obstetricians, all high-risk obstetricians, and everybody who does ultrasound scans is on the same page. The embryo is the actual baby between 0 and 10 weeks, and beyond 10 weeks, we call it the fetus. This was because in the old-fashioned ultrasound scans, an embryo, which refers to something that has no shape, was believed that is the situation of a fetus up to 10 weeks. Today, we know that that is not true, but we still refer to it as the embryo up to 10 weeks and beyond 10 weeks as a fetus. The word abortion is used as a patient choice for terminating a pregnancy, and natural events are referred to as miscarriages, and that is important. But of course, this applies to the earlier window. We know that the first thing to appear within a gestational sac is the yolk sac, and the yolk sac is always outside. There is the amniotic cavity, and in the chorionic cavity, we have the yolk sac, and the embryo will appear later, and the embryo will be there. And most of these are located eccentrically, and ultimately the yolk sac will cleave off from the embryo and have its own little vitelline duct. Usually the yolk sac is seen by the time you have a sac size of about 5 millimeters if you're doing a transvaginal scan, and about a week later if you're doing a transabdominal scan. But a good yolk sac should never be more than 5 to 6 millimeters. And therefore, there's been a lot of talk about outcome of pregnancies between 8 to 10 weeks and the morphology of the sac. But do remember that even if you have a thin, large sac, or you have a bright sac, or you have 2 sacs and 1 embryo, or you have an echogenic oval sac, or you have a very small sac with too many yolk sacs, then none of these is an absolute indicator of a bad prognosis. All of these can give rise to a perfectly good embryo, and the yolk sac has no consistent statistical relationship with the outcome of a pregnancy. And therefore, the most sensible thing is serial evaluation and no rush to condemn a pregnancy as bad or dead. It's very important to also realize that there are other soft criteria also that are used, and these include embryonic bradycardia. And we know that the heart rate can be quite low at the beginning of pregnancy, and it's only by about 8 to 9 weeks that it reaches a much higher level of between 130 and 170 and up to 180. But embryonic bradycardia should always be serially evaluated. Suboptimal embryonic growth is also worth following up. An abnormal yolk sac, an oligoamniotic sac, where there is much more embryo and you can't fit in the second embryo within the same sac, that's the best way to look for oligoamnios rather than measurements, or a various variety of hematomas. All of these, along with the peritrophoblastic hyperemia, can result in a perfectly good pregnancy and therefore never been a rush. Therefore, these are called soft criteria. Just reevaluate all of these at 8 to 10 weeks. And when you call them back, and of course, in some cases, you might call them back at 6 to 7 weeks, always look at embryo morphology because therein lie great clues which we are going to discuss. So this is also a group where you will call them back for an assessment of the embryo. The evaluation of the early embryo is always done by 2D, and although we can make very exotic images like this with 3D and 4D, that's not the idea. We really must be making 2D images and of course a transvaginal scan. We will discuss that again in a little while. There are two sets of measurements to be taken, the crown rump length and the embryonic heart rate. And if you don't see the embryo, of course, you do a mean sac diameter, which is the inner to inner diameters in two images that are perpendicular to each other. And you take out a mean of those three readings and you read it off from a chart on the machine. Remember that this should always be expressed, the crown rump length should always be expressed as millimeters, and also weeks and days depending on which chart you use, and mention the chart that you're using. And that dating a pregnancy at this time is the best way to assess and assign the EDD. It's as good as calculating from the ART cycle. And therefore, it's a good idea to always do this at the right time. But again, remember that we just don't use this as a dating and a viability scan. Today, we look at the embryo as well, and let's see how we go about this. We use high-end technology, and there is truly no choice but to use this high-end technology, because that's the only way to understand what is going on. And we, to the extent possible, should use transvaginal scans because the resolution is far better. Transvaginal scans, like I said, are completely safe. You could get a lot of the information from a standard transabdominal transducer, or a standard 3D transducer, or a matrix transducer, or a single firing transducer, or a linear array. You need all of those in specific situations. But the vast majority of work for detailed anatomy is done by a transvaginal scan. And to this, we add on the technology of 3D and 4D. And where necessary, we like to add technology of vascularity as well. And the other thing is that instead of using a low-end transvaginal transducer, the usual 3 to 6 or 5 to 9 megahertz, it's sometimes worth it at this stage to try a 6 to 12 or 15 megahertz transducer, and that can give you spectacular images, both in terms of surface anatomy in 3D, in terms of sectional anatomy and see-through anatomy, as well as add-on color information. Excellent. For instance, here, and you know, this is one of my favorite cases. We're sitting at about 7 to 8 weeks because we can make out the morphology of the posterior cranial fossa here. We have a heart that is beating outside the thorax, so obviously nectopia cordis. We have a bulge below that, and the cord insertion is below this. And then between the cord insertion and the lower part of the embryo, there's only a shaggy structure. And so what do you think this is? This, moving on, this is what embryos look like on surface rendering in 3D. But that does not mean that we need to render every one of these. It's just that there is a pattern you can recognize that you have to tune your mind to. And because of that, you will be able to figure out that this is a normal or an abnormal embryo. At 7 weeks, the embryo is actually L-shaped. And I will just have that back in a minute. There is my slide. So there is an almost right angle between the head and the trunk at this stage, and you have just about the beginnings of the limb buds and a fairly thick umbilical cord. At about 8 weeks, we realize that the embryo tends to become more of an open C, that the upper limbs are far better developed than the lower limbs, and the cord has become thinner. The embryo has some nice normal curves, such as the anterior abdominal wall curve. Both hands are in front of the thorax, and as we move on to 9 weeks, we realize that the limbs grow longer, that the lower limbs start becoming even longer, that the cord becomes thinner, but you could get a physiologic omphalocele, which is the thickening at the base of the cord before the bowel goes back. And depending on your settings, it would be seen better, and depending on the amount of bowel. And then, of course, you get your classical 12-week appearance. So this morphology of the L shape, a wide C shape, anterior abdominal wall, limbs, and a head that is much larger than the trunk is the normal morphology this time, including a physiologic omphalocele. Now, do remember that when you work on this and you do 3D images, it's not enough to just do transvaginal scan. You do need to filter this information, and therefore we use compound imaging and we use also speckle reduction. And with that kind of filtration, this kind of an image becomes like this, and you can see how beautifully now you can see the forebrain, the midbrain, for the top of the brain here, and of course the cavity of the rhombencephalon, which you see at the back over here. So the aqueduct sylvius is seen right on top. It's right on top of the brain, and it's not unusual to have a bump at the back of the brain at this time, and we will not mistake that for an early meningocele or a cephalocele. You can then go on to use a technique of filtering out the grays, and when you filter that out, you see better through the embryo in 3D, and so therefore you will of course see the yolk sac, but you will also realize that you can see the brain much better and the fourth ventricle far, far better. You can then play around with the transparency on these images. You can play around with the silhouette function, which is the lack of shadow function, and with the 2D gain to get images like this. If you cut away the rest of the information and do what we refer to as depth magic cut, then you will get much better outlines like this, and see how excellent you can see that the brain itself also is L-shaped, that this is a 7-week embryo that is also L-shaped, and that you can make out the forebrain, the midbrain, and the hindbrain very beautifully. And this is the normal morphology, and it's beautifully lit. This is a technique first described by Bernard Benoit, and it's a great technique to learn. It's simple to learn. There are enough tutorials on the net, and we could discuss it in a workshop in the future as and when we start live programs. Now, this is what happens at 8 weeks. The moment we start using that silhouette function, we do realize that the ventricular system has become smaller. You may not be able to appreciate both lateral ventricles in a sagittal view, but you certainly see the left and the right when you look at a frontal view. You can rotate these with 3D. Remember, now by 8 weeks, the C shape is going to begin, and that the length of the umbilical cord is equal almost to the length of the embryo. And then you're quite sure that, okay, even in the future, this cord is going to remain long enough. Remember that by 9 weeks, there is an excellent progress in the ventricular system. And by then you see again the lateral ventricles, the third ventricle, and look how beautifully the shelf has begun to appear in the hindbrain, in the cavity of the hindbrain, and that will then divide it beautifully into the future fourth ventricle and the future cisterna magna. And you can of course make frontal views, you can make sagittal views, you can make oblique views, and get the information you're looking for. And as I will show you, this is critical information for abnormalities of ventricular development, so that a holoprosencephaly can be diagnosed now as early as 9 weeks. So it's not just 2D that we make use of, it's not just 3D or high-end 3D surface rendering we make use of, but high-end technology function that tells us about ventricular system, and as we will show you, other parts of the embryo as well. As we move on to the window of about 10 weeks, we have further development, and here now the relationship of the third ventricle and the aqueduct remain vertical, with the aqueduct forming the uppermost portion. There is not much you can see in 2D at this stage because the choroid plexus has started enlarging. But again, the moment you switch on the silhouette function, you can see the brain really beautifully formed, pretty much like what it's going to be as between 11 and 14 weeks. Remember that even if you don't have the silhouette function, you can use alternate functions of not just having to depend either on surface rendering or 2D. You can draw a line which can be drawn along any direction through the embryo, like this one, for instance, passes through the ventricular system, through the aqueduct, and through the hindbrain, and down through the spinal area, so that this is the kind of detail you get: the lateral ventricle, the third ventricle, the aqueductus sylvius, and the fourth ventricle. Remember that this has in itself normal variation, so a nice rhomboid shaped rhombencephalic cavity or a globular one are both normal future fourth ventricles, and we will not worry about them. This is the way they are. And you always draw a line across like this. This is something which is easy software available on most medium and high-end equipments. You can also do multi-slice imaging, and that can be very, very useful, because if you have the plane correct, you can see all of this right through and through, and that's so easy to handle. Also, this becomes very easy to archive and study at a later stage in case you need to look back at these images anytime. So technology helps you to do that as well. Remember that the business of looking inside the fetus is not just about looking at the brain cavities, it's about looking at other things. But while we're on the brain cavities, if there's any structure you want to localize, for instance, I want to know what is the structure on the top of the brain, I will put a dot in it, and I will see where is my dot coming on the other parts, in the B plane and in the C plane, and here I am on top. So I know that, yes, this is the aqueductus silvus. If I'm going to be putting my dot right here in the middle, then I know that, yes, it's now coming here at the back of the brain, here at the back of the brain. So this is now in the cavity of the rhombencephalon. So these are the techniques of 3D that help us to localize. And in case you see an odd looking structure, you will be able to see fetal morphology at this stage. In fact, this is the time that you can even start recognizing early ventriculomegaly in the aneuploid fetus if you are sensitized to it. And I'll show you an odd slide to show you that. Remember that this is now standard, and you can do it even with the 2D, because the other thing that 3D teaches us is that it's not just important to be doing everything the 3D way, but the more you see on 3D, the more the mind learns to recognize 2D. And therefore, the divisions between forebrain, hindbrain, and midbrain can be seen as an L shape here at 8 weeks. On 2D, if you focus correctly and you turn your transducer and wait for an ideal position, the ventricles start becoming large in size at the beginning of the 8th week, become largest by the end of the 8th week, and a C shape starts happening. And at 9 weeks plus, the ventricles become narrower and narrower, and the morphology of the hindbrain begins to form. And by 10 weeks, it's almost like the morphology we're used to seeing at about 11 weeks of gestation. Remember that the more you do 3D, like I said, the more you're going to be able to recognize on 2D. And a lot of us no longer have to depend on 3D because our minds have started to think morphology. And therefore, all we do is to wait patiently, manipulate the transducer, look at other things in the meanwhile, a small cord cyst, which may or may not be of value. And then we turn around and we recognize more, not just the ventricles, but the position of the heart. We also recognize the fact that the back is normal, that the anterior wall is normal, that the cord is originating at the correct point, and the head is generally much larger, but you have to be patient. The advantage of 3D is that you don't have to be patient. You do a sweep, and 3D is always preferred over 4D because resolution is superior. 4D, as you know, is real-time 3D. And then you can twist and turn, rotate and slice exactly the way you want. And therefore, the quick way to achieve results is 3D. And here again is choice of machine. Do not, in today's day and age, pick up a machine that's going to say, look, you can't do 3D on this. No, the lowest end machines now have this available at about the same price range. So be very careful when you invest your money and that you're getting good value. This whole study of the inside of the brain started with an old technique that we used to call inversion mode. And this was done by Gianluigi Pilu. And he was the first to show us, and then Timo Trich in New York also developed this beautifully. So between Italy and New York, we got to see the first images where the original images in 3D were converted to show black and white in black. And therefore the ventricular system became prominent, like I showed you. This involved a lot of threshold settings, was never easy to use, never user-friendly. And then, although it showed us beautiful images like here, which again is from Pilu, and the recognition of early holoprosencephaly, notice that at 7 weeks in holoprosencephaly, the brain is more vertical than L-shaped, and it becomes balloon-like by about 10 weeks. So very early recognition just because the L shape went away, but we don't use this anymore. We've learned that from my 2D sections itself or my 3D with a multi-slice sectioning, I can start recognizing exactly the same structures, and I don't need my inversion mode anymore. I might use the silhouette mode because it is easier, the one or the outline that I showed you, seeing through the embryo, but we don't use this anymore. The other thing I want you to remember is that at this stage, there is a very interesting relationship between the axial and coronal planes of the fetal body and the axial and coronal planes of the fetal cranium. So the axial plane of the corona of the cranium is parallel to the coronal plane of the body. And the coronal plane of the fetal brain or the embryonic brain is parallel to the axial section of the embryonic body. So you must realize when you're slicing through that you must have this information at the back of your mind, and don't get suddenly confused that, look, I was working with coronal, how did I become axial for the rest of the fetus? It's because of the degree of flexion, the L shape and the C shape before the fetus becomes a wide curve. Now, today, when we talk about technology at 7 weeks, we do realize that we do the good old recording of our M mode for the heart rate. We do realize we do measure crown trump length, but we are far more sensible. We try and see the beginning of ventricular anatomy, and we make sure we get a nice long, maximally long section of the embryo. We look at the adnexa and we look for the yolk sac and so on. And then we watch out for heartbeat and we make sure that, yes, the amnion is well defined. Beyond that, very often, because now we have the technology, we started looking at everything in 2D itself. But when you don't get this image easy, like I said before, it's very easy to resort to 3D. So make sure that every vaginal transducer that you buy must have a 3D and a color facility on it. And the prices are very, very comparable. Don't let anybody make you believe that that's not possible. And this is a piece of embryology that I like very much from Ravi Chavi's book on the first trimester ultrasound diagnosis of fetal abnormalities, a wonderful book by Abu Hamad with my friend Ravi Chavi. And they've clearly shown us, and these are their images, that there's hardly any spine at 9 weeks. There is a very faint spine at 10 weeks, 4 days, and therefore in the embryonic period, it doesn't seem correct to actually talk about the spine, although you might be able to identify meningoceles and cephaloceles and so on, but don't go for spine ossification at this window. Spine ossification is best after 12 weeks of gestation, and that applies to the axial section as well. So in embryology, up to 10 weeks, we're not looking at ossification of the spine, but we do look at the outer curvature of the embryo. And this is something that is necessary because interruptions of this can be the first sign of open neural tube defects. And of course, then you'll go back and look inside the brain and you'll be able to identify those as well. The other really useful thing at this stage is to identify zygosity, chorionicity, and amnionicity. We know that zygosity cannot be defined on ultrasound so far. Chorionicity and amnionicity, yes, because that determines the prognosis of pregnancy. Here again, there are ways, the traditional ways of going about it, the number of sacs, the number of yolk sacs, the number of amniotic sacs, the thickness of the amniotic membrane, the twin peaks sign and fetal gender. But technology helps you here again. Look how easy it is now on 3D to identify the twin peak sign as early as, say, 6 to 7 weeks of gestation. How you can use the silhouette mode to beautifully identify 2 sacs versus 3 sacs, or more than one embryo within a single sac. And therefore, we make the best use of technology. This is all transvaginal 3D, and it's so easy to do, so easy to perform, and you get results much faster. So your patient throughput is also much better, and it's truly worth using. Now, when we look at fetuses, or embryos as we should call them at this stage, we must look at anatomy and heartbeat. If I find that a fetus is bottom heavy, and the top of this embryo at about 8 to 9 weeks is narrow, I start wondering which is head and which is body. Then I look for the umbilical cord, and wherever that is starting is the lower end of the fetus. That's the caudal end of the fetus here, and this is the cephalad end. And the reason why this embryo appears like this is that this is very early acrania. So acrania can now be diagnosed as early as 9 weeks plus, and this was the normal one. This was this fetus at 9 weeks plus, suspected acrania. In those days, we weren't so comfortable, and then we just called them back after a week. And by that time, at 10 weeks plus, it was very clear that yes, there was no calvarium, And in fact, there wasn't very little other kind of activity in terms of the fetus as well, and certainly no differentiation of the kind we expected. And the wider end had the cord originating, and therefore we know that yes, our diagnosis is confirmed. So here is a diagnosis confirmed way before the 11-week window. In fact, sometimes you might have a doubt. All you see is a bit of diffuse hydrops and a poorly defined calvarium and a little bulging on the sides. We know that this is the sequence where acrania is developing and will go on to anencephaly and go through the phase of exencephaly. And all you have to do is to look at them carefully, recognize this pattern, identify, and you don't have to call them and make them wait to 12 weeks to give this diagnosis. So obviously a lethal abnormality, and this must be diagnosed as early as possible so that we don't have to wait, because we know that terminations of pregnancy are best done early. Yes, 12 weeks is better than 18 weeks, but 8 to 10 is even better than 12 weeks, because by 12 to 14 weeks, we have a fair degree of damaging the endometrium. And that is not something we want. We don't want Asherman in her next pregnancy or before her next pregnancy or infertility and so on. And therefore, the right way to go about this would be to identify these as early as possible. So most of the acranias are now being picked up by about 9 weeks of pregnancy. Another embryo here, and what was interesting here was that at 8 weeks plus, there was an oligoamniotic gestational sac. There was a fairly large cavity within the hindbrain, globular, and an irregular, bright, oval-shaped yolk sac. And the fetus comes back, and sure enough, we have a abnormally bulging large structure here, and we have no cardiac activity. So all of this gets diagnosed early enough, provided we use it early enough. There's been a lot of evolution in our thinking in this 8 to 10 weeks window, and one of the greatest thinking has been a new model of antenatal care, which has been put forth by Simon Marr at Monash, which as you know is in Melbourne, and this is for the IVF unit there. They have a dating scan, which confirms viability and a number of pregnancies, excludes an ectopic, and calculates the EDD. But then the patients come in for an NIPT, because that is now the new model. We have to be ready for this model as well, because the cost of NIPT is becoming lesser and lesser. It is very likely that NIPT will become affordable. NIPT might even move into the realm of public health care, but anatomy will never move into that realm. So a lot of people are now for the IVF and high risks following this model of care, where at 10 weeks, the fetus comes in, you confirm that yes, a number of fetuses, and you send off the NIPT sample, but it doesn't stop there. You do a full anatomic evaluation, and then you schedule your next scan, not at 11 weeks, which is too early, not at 14 weeks when the fetus becomes, or 13 weeks plus when the fetus becomes vertical, but at about 12 and a half to 13 weeks, so that in addition to looking for the nuchal translucency as a marker of non-aneuploidy conditions, you can also see the rest of the anatomy and also do a preeclampsia risk evaluation. And that is how the whole system actually works. Because you've done such a good scan at about 13 weeks, the morphology scan moves to later 21 weeks, where you can pick up much more. And of course, their rules for termination of pregnancy are different. And then of course, they have a term scan. But this model of antenatal care seems to work beautifully in patients who can afford it, and also in IVF patients. It also works very well in high-risk patients, and I will discuss this briefly. This is the protocol given by Simon and his group, and they say that they calculate CRL, yolk sac, and sac volume if necessary. In a transverse sweep, they like to look at the limbs. The feet are often apposed at this stage, and they're difficult to see, and it's not possible to count the digits, but we try and look for them. The femurs are always looked for, and if you can see the tibia and fibula, that's fine. Otherwise, you may not be able to do so. The cord insertion is looked at, and we make sure that there's no omphalocele. There could be, of course, a physiological omphalocele, but you look very carefully, and then you see what is the relationship of this to the cord and the width of the base, and you go by the width of the base. You confirm that there are 3 vessels in the cord and that you are looking at the bladder and the kidneys. The kidneys are again best seen in a coronal section of the embryo, and not in an axial section of the embryo. You move on to try and see whether there's a bulge in the spine area, although we can't see the spine, and you try and identify the diaphragm. And that is only in terms of the relationship between the liver and the lungs, and not actual visualization of the diaphragm. The heart evaluation includes a 4-chamber and an outflow. Clavicles are not compulsory, and you only look for them in specific situations. You look at the ARSA if there is an edema of the nuchal area. You try and see the profile very carefully, and the ears might show up often. The mandible and the maxilla and the upper lip are looked for. The arms are usually across the chest, but you can look for humeri, and this is the best time also to look for abnormalities of the absence of one of the limbs, although 5 fingers may be seen in some, but not in all. And therefore, essentially what we do is try and do as much of this as possible and not everything. Certain diagnoses at 10 weeks can be absolutely definite, such as body stock anomalies and acranias like I showed you. You still do the nuchal translucency because it's a marker not of aneuploidies, but of other conditions as well, such as cardiac defects, such as skeletal defects, such as the metabolic disorders and so on. And of course, large masses in the chest, which are rare at this time. But if you don't train your mind to see this now, you will never see it. And therefore, it's important to recognize that pattern recognition plays a major role here as well, that you tune your mind that, look, if I see this like this, and I don't see this like this in the other fetus, I will call them back for an early review because I suspect it, or that I'm so sure at the moment that this is something wrong, I will go ahead and label this individual. And there is no doubt that the closer we get to 10 weeks, that's nicer. And 10 weeks is also good because by then, if the BMI of the patient is not too high and everything is okay, they go on to an NIPT evaluation. If, of course, you find a structural abnormality, we follow the same protocol as we do for 11 to 14 weeks, which is invasive testing. So now let me see a few examples of how this works. We already know that we no longer do unmagnified views like this only to look for heartbeat and leg. No, we look at details, and the details we like to look at 10 weeks is the 4-step evaluation in this screenshot that I've taken from Simon. And it says that the topmost area is the fox and the choroid plexi, which almost completely occupy the lateral ventricles. Remember that at this stage, the aqueduct of Sylvius is far more posterior, pretty much as far back as it appears in open neural tube defects as we see at the 11 to 14 weeks window. So remember at this time that it's a larger aqueduct and it's far more posteriorly placed. Also, that there could be this communication, which we always see between the 4th ventricle and the cisterna magna, lower down below the level of the aqueduct, and that you identify the choroid plexus within the 4th ventricle as a structure that you can truly see. And then when you look at it and you look at this structure, I say, okay, I see this aqueduct, it's big and it's at the back, but it's 10 weeks one day, this is normal. I see this, I see a very triangular shaped structure with bright walls at the back and a possible communication here, a pointed area, but I know this is normal. This is normal for 10 weeks, and this is the protocol set by Simon. This is far better seen in axial sections than in sections like this. Remember, when you do 3D, don't do blotched 3Ds like this one here. No, it makes no sense. Yes, you can see the ventricles are there, but not as good and as much morphology as you would see even with the 2D once you get used to 2D. So be careful when you use 3D, learn how to use and use it correctly. Otherwise, go and learn how to do it correctly or teach yourself how to do it correctly. Remember that you can identify holoprosencephaly at this time of the alobar type at 10 weeks. Transabdominal scan, suspicion that there might be a ventricle that has not cleaved, biggish ventricle. Vaginal scan, or straightforward, you can see a single large monoventricle, 3D reconstruction, large ventricle communicating with this large cyst at the back of the brain, which is the usual thing that we find. Large cyst in front, large cyst at the back of the brain, and a communication between them. The trick here is, yes, you realize that you're looking inside. You're not depending on transabdominal. You're looking for anatomy. Therefore, you will find anatomy. You will find a direct sign, and you will make a diagnosis instantly. Initially, you may not have the confidence to say, yes, this is a alobar holoprosencephaly. You may not make the diagnosis at 10 weeks. You'll make it at 12. But as time goes on, you will at 10 weeks be able to facilitate a termination of pregnancy in case the patient wants to terminate this at 10 weeks of pregnancy, which is much safer. Another example here, and there's one example in the top row and one in the bottom row. ventriculomegaly, obviously large ventricles compared to the choroid plexi. Remember, we use the same parameters, which is we don't measure for 10 millimeters as the width. No, we compare the length of the ventricles with the length of the choroid plexi, or the area of the choroid plexi with the area of the ventricles, or the diameter of the choroid plexi with the diameter of the ventricle, just as we would do at 11 to 14 weeks. We then do a multi-slice to confirm that diagnosis, and a 3D reconstruction clearly shows that yes, that the ventricles are showing here as very roomy, and the choroid plexi are not that large, and there's plenty of extra fluid there. Second case here, suspicion that there's too much fluid in this brain, suspicion that there may be something at the back, and the moment I use this software which allots color to ventricular spaces or water spaces, Sono AVC, I find that there is a meningocele here in the occipital area, and it's communicating with the fourth ventricle, and that the ventricular system is prominent. And this then, when we look back at this fetus, looked at more carefully because we found a cephalocele. We looked for polydactyly, we looked for echogenic kidneys, we found them both, and therefore we had a diagnosis at 10 weeks of a Meckel-Gruber. Went back into the history, the patient said, yes, I've been losing babies, but I have one kid, which is exactly what we expect. And this would have turned out to be Meckel-Gruber, but we made the diagnosis at the right time. Genetically, this again showed exactly the same genetics as we would have expected in a Meckel-Gruber. Space at the back of the neck might be edematous even in normal individuals, so don't overlabel. It can happen in twins, it can happen in normal embryos, it can happen in abnormal embryos. So when we find nuclear edema, don't be in a rush to label it as abnormal. There could be a fair number that are normal, but do start looking much more. For instance, other abnormalities, cardiac abnormalities, excellent visualization of the outflows, but a fairly lopsided visualization of the chambers, and we see only one side of the heart filling really. And therefore we know, okay, this is an early abnormal heart. Not so easy to pick it up when we look at images like this, but very easy to appreciate when you do a high-end 3D 4D stick evaluation like this particular one. So way beyond surface rendering for embryos, we're going into looking at inside anatomy, and then you will get all the answers. And here again, you look very carefully, big yolk sac, otherwise looks okay. And then I do a rendering. Rendering is always easy at the 18 to 10 week window because there's always plenty of amniotic fluid. You don't need any rocket science, how much curve, how much no curve, how much this, how much that. Sure enough, you say, okay, I just make any 3D, it will always give the answer and confirm my 2D findings, which is cranium, a heart, and part of the back outside the anterior wall of the chest as well as the abdomen. And exactly the same finding here. Back wall of the embryo fine, cranium of the embryo fine, heart lying almost entirely out of the thorax, and bowel lying almost entirely out of the thorax. And that's what this was when it was confirmed later on. Moving into the thorax, pleural effusions are almost always pathological. A pericardial effusion is not rare. A very tiny pleural effusion not rare, but fluid like this outlining the lungs like this is definitely pathological and needs an adequate follow-up. But this, you have time to follow it up here. At the time when we do blood, we would then therefore also look for CMV infection. We would then also start looking for other conditions that are associated with pleural effusions and hydrops. And therefore the workup becomes much quicker and much easier, so that by the time you have your 12-week window, there's no time to be wasted and you have an answer between 10 weeks and 12 to 13 weeks. But the only way is that if you tune your mind that I will not just look at the embryo as a blob, but as lungs, as pleural effusion, as liver, as bowel, and then I will get my answers, then you will be able to facilitate patient decision-making at a time that is useful for the patient. Remember that there are the usual variants of physiological herniation of the bowel, like we've already discussed, and it could be fairly large at 9 weeks, could be fairly large at 10 weeks, but usually by 11 weeks plus, these have gone back. And if they haven't gone back, we use the usual measurements at 12 weeks, but we don't label them as omphalocele straight away because the vast majority of them would be small, They would be minimal. They would be only at the base of the umbilical cord, and you have a cord insertion at the apex, and you know that this would be physiological omphalocele. Now, the limbs may not be so easy to see because the feet often face each other, and therefore on 3D, counting of the toes may not be possible. However, you can look for presence of both upper limbs and both lower limbs, and the proximal, the middle, and the distal segment of all of them. And if you're really looking for a syndromic situation, you can go back to 2D and start counting digits like this. Like this with that same Meckel-Gruber. We looked and we looked and we found polydactyly. Remember that this work has to be done vaginally. When you do abdominal work, things show up, no doubt, but not the kind of detail that you would like to see in terms of anatomy. So therefore, you must try and see it. Remember that there's an embryologic timetable. A lot of things may not be seen at 7 weeks, but only be apparent at 9 weeks. And a lot of things would therefore be apparent also only after 11 to 14 weeks, and some not until 22 weeks of gestation. So we must realize that what I said before, that we do need the 11 to 14 week scan, which preferably should be done at 12.5 weeks, which means at about CRLs about 70 or so. Those are really the most comfortable. And then we can then postpone, depending on the legal environment, of pushing our anomaly scan a bit as well. So what's the message I wanted to take home? I want you to realize that scans between 7 to 10 weeks have to go beyond observation of cardiac activity, dating, and number of fetuses. And we have to look at morphology. We have to use transvaginal scans liberally, and preferably we have to use a high frequency transvaginal transducer. We have to use technology liberally because it helps me to make an early diagnosis. It gives me information that's not possible on 2D. It gives me information that is much more fast to obtain compared to 3D. And in COVID times, believe me, I'm sure that's going to be very useful. Also, you have to tune the mind to embryonic morphology, and I've initiated this process, but do look at these videos from Simon Ma and Bernard Benoit and read that article in the May issue of the journal. Remember that this 10-week scan can facilitate scheduling of NIPT. If there's structured abnormality, no NIPT. And then beyond that, I will call my patient back between 12 and 13, not at 13 plus or 11 plus. And then of course a 20-week scan. And then I would be doing my best. What's the downside? The downside is you do need expertise. Cost of equipment, it's not the lowest end, you need medium or high end. The embryological timetable, you can't avoid that. The other thing is inducing anxiety when there might be a normal variant versus something that is evolving versus something that is completely abnormal. That's a small price to pay for early diagnosis, early investigation, especially from genetics, because we know now that genetics is so sophisticated that we're truly getting quite stuck without having that time frame. And this gives us that time frame. And thank you so much for your attention. These are the images we look forward to. These are now becoming state of the art. And see how beautifully we're looking at the heart. We're looking at the umbilical arteries, the umbilical vein, the ductus venosus, the vasculature going all the way into the brain. And this is the kind of detail that we're able to see today. Thank you indeed.
Thanks again, Dr. Khurana sir, for such informative session. We received an overwhelming response with around 2,000 attendees joined here in total via our 3 platforms that we are transmitting this live. On behalf of Sonoscape, I thank everyone who joined in today. As you are observing, Sonoscape is prominently conducting numerous ultrasound webinars regularly with support of key speakers and luminaries across India. We will continue to bring to you many more such sessions going forward also. Thanks again, Dr. Khurana sir, for your support as ever. With this, we will end the session. Thanks, sir.
Thank you. Mahendra, are you giving me the questions or?
Oh, sorry, sir. Yeah, sorry. Sir, can you, okay, I will read out the question, sir. Hello.
Yeah. Or should I just log into the chat window?
If you want, I have it in front of me.
Excellent. So if you can read out the questions and I will be able to answer them. Thank you.
Right, sir. Sir, what is the FHR to define fetal? What is the FHR to define the fetal bradycardia at 6 weeks?
Um, at 6 weeks, we don't give a label of bradycardia. It could be just too early. And we like to wait till 7 weeks. It has to be 110 beats per minute at 7 weeks onwards. So at 6 weeks, if I'm picking up less than 90, perhaps, but you never know about the time of gestation. So never be in a hurry to label bradycardia at less than 7 weeks.
Right. We have a lot of questions, but let me, okay. What precautions we should do when we do scans during COVID times?
Not connected with this webinar, but for your information, we truly have a very, very nice set of guidelines from the Society of Fetal Medicine. And it tells you exactly what ultrasound practitioners on an outpatient basis should be doing during these times. It's a very elaborate document. We released it about a month and a half ago, and it's available free on the internet. It's called SFM Guidelines for Ultrasound Practitioners during the COVID-19 pandemic, and it's a free download on the internet. You will just have to Google it and you will find it.
Right, sir. Dr. Rekha has a question. I am unable to appreciate M mode for fetal heart in early pregnancy. Please help in suggesting.
Can you repeat that? Unable to appreciate what?
M mode.
M mode. You see, one of the problems we do in M mode is that we have the heart in the upper panel and we have the M mode tracing in the lower panel. And we often have a very slow sweep speed for our M mode. If you were to put on the left side of your screen the embryo, and on the right side of the screen you run the M mode at an equal level, and you increase the sweep speed and you magnify the embryo and the gestational sac, you will always be able to make out the fluctuations and make sure that the beam passes through as much of the heart as possible. If you take these precautions, you will always be able to see M mode.
Right. So Dr. Ritu has a question. She's asking, sir, when you say we do scan at 12.5 weeks, do we assume NIPT is being done at 10 weeks, or for all patients, we can do the scan at that gestation?
We should always, irrespective of whether NIPT is done, because it's not routine practice in our part of the world so far, always try and do your scan later than 12 plus 0, because 11 plus 0 is very poor for anatomy, and before 13 plus, because then the embryo or the fetus becomes too vertical. The fetus becomes vertical like this, and you can't get such a good view. We want the fetus to be in a nice supine position. So when it's vertical, you don't get a view from the vaginal route, you don't get a view from the abdominal route, and it can be very difficult to manipulate because the fetus is actually lying still behind the pubic bone. And therefore, it's wiser to do these, if you can schedule them, between 12 weeks, 0 days to about 13 weeks in a day.
Right. Dr. Atul Kumar from Hyderabad has a question. He says, sir, I missed a case of twins at his question is, I missed a case of twins at 6 to 7 weeks.
Yes.
Can we miss twins and label them a singleton in early pregnancy scans?
You do not have to be worried about missing twins. We know that amnions can be very, very thin and you may not spot them. They could be twins growing at different speeds. You may not see them. You might have one tiny sac lying in a cornu. And we know that 99% of twins should be identified, and you have all the way up to 10 weeks of pregnancy to do so. So it's no crime to miss a twin at 6 or 7 or 8 weeks of gestation. Yes, if you sway your transducer from side to side, that means you survey the entire uterus and its contents from left to right, anterior to posterior, and superior to inferior, you're extremely unlikely to miss them, and do it slowly, spend some time. But in the best of hands, with the best of equipment, you might miss twins and the type of twins, especially twins, not so difficult, but more, the chorionicity, the amnionicity, all the way up to 10 weeks. By 10 weeks, you should be well in place, but 7 weeks, no problem, not a crime.
Right. Thanks. Dr. Vandana has a question. Any significance of DV Doppler at 10 weeks, or should we avoid?
I do not use a Doppler unless I found other abnormalities. So if I find something seriously wrong, then I might insunate the ductus venosus, but otherwise, or I might, use an odd vessel here and there. But by and large, I don't. The umbilical vein anyway can be very variable at this stage, and therefore I don't worry about that. But if I find other abnormalities and then I want to do the ductus venosus, then I say, okay, I will look for it.
Yeah, thanks. One of the doctor from Hubli has a question.
Yeah.
Sir, how do you counsel the patient when you suspect some anomaly at around 10 weeks? Do we reveal it to them, put it on paper, or just inform the referring doctors, or call them at 12 weeks?
No hard and fast rule, because this is biology. There are some abnormalities which are straightforward: acrania, holoprosencephaly, body stock anomaly, conjoined twins. These are straightforward. And we say, okay, very poor prognosis, take a choice. Would you like to continue? Would you not? Brain not well defined. I'm not sure it's correct. There's little roundness, little enlargement of the fourth ventricle. May be okay, may not be okay. We say, well, things seem to be all right, but let's be absolutely sure, and we come back at 12 weeks. So depending on the kind of diagnosis, I would be definitive in explaining or not explaining to my patient. And I would always take permission from the clinician on whether I should be counseling in detail or not counseling in detail. I know the Indian patient expects a lot of counseling because they like anything that comes free of cost. And we know that we as doctors love to give everything free of cost. It's a stupid mentality that we have to get out of. We don't appreciate our own values, but that apart, I always check, and I know my referring doctors well enough to know who should be counseled, who should not be counseled. That has to be on an individual basis.
Right. Yeah. Dr. Jain from Bangalore, his question is, how often we should use transvaginal scan at 12 to 13 weeks? And we should use it always?
Yeah, at 12 to 13 weeks, there is a tendency for those with a background in obstetrics and specialize in fetal medicine to always measure the cervix. I'm not sure about the logic of that situation, because even if you do the course of the Fetal Medicine Foundation that they have on the internet, it doesn't talk about it very much. But we like to predict things, and we say, okay, this is the risk for preterm, spontaneous preterm birth, and so on. But in terms of fetal anatomy, if the fetus is in a favorable position, it's excellent. So what I do usually is that at the 12-week window, I will try and do my markers for aneuploidy transabdominally, which is nuchal translucency, evaluation of the nasal bone, ductus venosus, and a detailed evaluation of the heart if possible. If I'm satisfied with most of the anatomy and there is no high risk feature and it's not a second opinion scan, I would stop there. If I find that I could change over to a superior transducer, I would try that. And if that doesn't give me the answer and my fetus is in a favorable position, I would do a transvaginal scan. So it is not something routine. Later in pregnancy, when I have to assess the cervix as a consequence of having to assess the cervix because of risk of the need for identifying the risk of spontaneous preterm birth, I would then do a vaginal scan anyway, but not at this window always, certainly not. But when I do my 10-week scan and I do my 7 or 8-week scan and I need to look at morphology, I almost always do a transvaginal scan.
Right. So Dr. Alpana from Sangli, her question is, can you please elaborate about the IT at 10 weeks?
Yes. Now, generally, the intracranial translucency is far larger at 10 weeks than it is at the 11 to 14 weeks window. Rather than the thickness or the thickening of the brainstem, which have not occurred at this time, we look for globularity of the cavity of the hindbrain. And if you find a very globular outline, then you need a follow-up. Otherwise, it is not a predictor for open neural tube defects if it is not seen. And you can barely see the IT very well, except maybe at 10 weeks, 4 days, or 10 weeks, 5 days, in which case the battle is lost anyway. I'm talking about making diagnoses from 7 weeks, 2 or 3 days to about 10 weeks, 1 or 2 days.
Right. Dr. Nitin from New Delhi has a question. What is the earliest time to access nasal bone? And should we always access it by TVS probe, nasal bone?
The nasal bone is, of course, not of value between 7 and 10 weeks. The nasal bone is of value in the second trimester ultrasound scan because the length that you see of the ossified nasal bone is a very good predictor for aneuploidy. It has a very good likelihood ratio. At the 11 to 14 weeks window, we just see whether it is present or absent. I like to measure it because whatever I measure, I focus better. My image is better. So that's why we do it. But we know that in the Indian population, it can ossify late. We know that in a large population, it can ossify late. And we know that a large number of Down syndrome babies will have a normal nasal bone and a large number of absent nasal bones will be present in the normal population. Therefore, I don't attach much importance to it, but I always look for it.
Right. Thanks. Dr. Suman from Hubli, how to diagnose scar ectopic pregnancy and what is the management?
I wish I could do a webinar for you right now on this. It's a topic by itself. And I'm sure the Sonoscape team will put this together for us for talking about scar pregnancy. It's a topic by itself, needs to be done justice appropriately, not something I can cover with a 1 or 2 minute answer. Both measurement of the scar at the end of pregnancy as well as the diagnosis and management of scar pregnancy is a topic by itself, and we'll keep it for some other people.
Right. Dr. Ganesh has a question. How to detect trisomy?
How to detect, sorry?
Trisomy.
Trisomy. At this window, well, the same things, which means I will look for nucleedema, which may be structural or maybe trisomy. I would look for a dilated cisterna magna, which could often be a marker for trisomy 13. I would look for markers of trisomy 18. I would look for cardiac defects, but not the kind of intense detection of trisomy 21 that we do at the 11 to 14 weeks window. No. At this window, either leave it to NIPT or call the patient back for an evaluation between 11 and 14 weeks.
Right. Dr. Kusuma from Chennai, at what gestational age is the best to calculate the period of gestation?
Traditionally, the Fetal Medicine Foundation likes to calculate this, and so does the RCOG, between 11 and 14 weeks. I don't think that is necessarily true. The fetus can curve a lot. And we know from the new guidelines from ISWAG, the biometry guidelines, that you can measure the fetus anytime between 7 or 8 to 13 weeks, and that will be great. I personally feel that 8 and 9 weeks is a really good time for calculating this, but if you are concentrating nicely and you're focusing your embryo nicely, then there is no question of making an error even at 6 or 7 weeks, or at 7 weeks minus. So if you have made the effort and not just done one random imaging of the heart without looking for the true length of the embryo, you're going to be wrong. But if you're doing it well, it can be as well done at 6 weeks. Otherwise, 7 to 14 weeks is a good time.
Right. Dr. Raman from Jammu, and the question is in form of a sentence. Size of yolk sac and pregnancy outcome.
We discussed that at length. Nice to have you on the webinar, Raman. We know that 6 millimeters, maybe 7 millimeters is the outer margin of the yolk sac, but a yolk sac by itself is not a strong indicator of an abnormal pregnancy, and I would always do serial evaluation.
Right. So as we are seeing doctors across India, so that's what the 2,000 doctors I mentioned, which are joined in. So Dr. from Assam, Dr. Fukan, in IVF, how the CRL is calculated with LMP?
We don't. In IVF, we go by the date of embryo transfer, and we very merrily presume the calculation on the basis of the dates of embryo transfer. Some people like to do it from the dates of ovum pickup. Some people from the dates of embryo transfer. Embryo transfers these days can be day 3 transfers, they can be day 5 transfers, they can be later transfers. And so, but we just use the embryo transfer as the date, and we go by the ART date, and we don't go by the crown rump length.
Right, sir. Dr. Ashfaq from Raipur, earliest anomaly of embryo can be detected at how many weeks?
Can I have the question again, Mohammed?
Sir, earliest anomaly of embryo can be detected at how many weeks? Whether Doppler study of heart should be performed at 6-7 weeks?
We've answered these questions during the webinar already. No Doppler study before 10 weeks. That means no spectral Doppler. You can do color flow mapping. And we're picking up anomalies, as I showed you, as early as 7 weeks.
Right. Another question. Do you think all patients should have a first trimester scan, or it should only be indications like bleeding, etc.? Please advise.
Yes, like we discussed in the first few slides, I personally feel that the scan is the best window for fetal well-being and for the prediction of what special care a mother is going to require during that pregnancy. As far as I'm concerned, a good ultrasound, a well-done ultrasound scan must be done at a dating and viability scan between 6 and 8 weeks. You do a good morphology scan at 10 and another one at 12 and then at 19 weeks.
Right. Dr. Amit from Surat, is enlarged amnion can be considered as sure sign of early pregnancy failure?
A large amnion?
Yes, enlarged.
No. It's very difficult to actually assess amnion. And so we don't really use that as an index at all. You could have a large amniotic cavity, you could have a small cavity. Oligoamniotic sacs often have a poor prognosis, but not a uniformly poor prognosis. And therefore, it's nice to do a mean sac diameter today, a mean sac diameter after a couple of weeks, and then decide whether the baby is good, whether the baby is bad, or whether the baby is dead.
Right. Dr. Anand from Raipur, can we see ductus venosus till 10 weeks?
Yes, you can see the ductus venosus at 10 weeks, and you can insonate it because by 10 weeks plus it would be safe. So I would not do it at 9 plus 6 just for the sake of doing it. You can see it. The flow velocity waveform will be the same as later, which means we will find forward flow, and we do not find the reverse pattern even at this stage. It doesn't contribute very much though. The actual morphology contributes more than just a ductus venosus. But you can look for morphology in terms that, look, is there a ductus venosus agenesis? Is there a persistence of the right umbilical vein and so on? But that is very useful for vascular mapping, but not the ductus venosus flow velocity waveform per se. I would leave that to my 12-week scan.
Right. Dr. Uma from Chennai, localization of FH at 6 weeks, correct or some easy way? Localization of FH. FH, yeah, at 6 weeks.
Yeah.
Correct? Yeah.
You do it. I mean, you record an M mode, and that's not so difficult. We explain the technique. I hope you enjoy doing it by the new technique. It should not be a problem.
Okay. Dr. Yadav from Aurangabad. Sir, please tell about hyperechoic embryo.
Embryos that are echogenic, maybe because you have a new machine and your settings are not right. It may be because you like brighter echoes, and that might be the case. Most echogenic embryos would be embryos that are dehydrated embryos, and or embryos that have had a bleed associated around them, and therefore they're unhealthy embryos. they need a serial evaluation to make sure what's going on.
Okay. Doctor from Chennai, the question is, can we pick up early embryonic anomaly 6 to 8 weeks by transabdominal scan?
Yes, sometimes you can. We have picked up conjoined twins. We have picked up a suspicion of a body stock anomaly. But the degree of confidence you get in a transabdominal scan, unless you have one of those wonderful patients who's 39 kilos in weight with a very thin abdominal wall, is so little that I always resort to a transvaginal scan to confirm the diagnosis. And if my patient feels that she can't have a transvaginal scan, I do a transrectal scan.
Right. So Dr. Rakesh from Delhi, his question is, what frequency TVS probe you recommend for scanning?
It depends on the duration of the pregnancy. And for my typical window that we've been talking today, up to 10 weeks, I like to use a 6 to 12 megahertz.
Right.
You know, when you move even into the 11 weekers, then maybe you don't want just such little penetration. So a 5 to 9 would be a good idea if you're like 10 weeks and 5 days. But otherwise, it's just so much nicer to be able to do these studies with a 6 to 12. The 3D becomes easier. The VCI becomes easier. The VSRI becomes easier, and so on.
Right. Dr. Balki has a question. What is the borderline? What is the borderline to report missed abortion from early intrauterine death?
The borderline for labeling? I didn't get this question.
Yeah. What is the borderline to report? What is the borderline to report missed abortion from early intrauterine death?
You don't use the word early intrauterine death at this stage. We always call it a missed miscarriage. An abortion is something that the patient opts for to destroy a pregnancy. A miscarriage is what nature does. So we call it a missed miscarriage all the way up to the first trimester, which is 13 weeks. And beyond that, we call it a fetal demise. So 13 weeks is the cutoff.
Right. Dr. Rashmi from Mangalore. Sir, what is the cause of oligoamniotic sac at such early gestation?
There can be several causes. The first is an inappropriate peritrophoblastic and trophoblastic circulation. You can have maternal causes and you can have fetal causes. The fetal causes is that typically fetuses that don't have a good proliferating trophoblast will have an oligoamniotic sac because that's really where the amniotic fluid is coming from. If you have an infection, you could again get an oligoamniotic sac, and this could be an intrauterine infection and a maternal infection. And you could also get it if there is a disorder in the mother that does not allow trophoblastic proliferation. So there's a whole host of causes, not a single cause, and it's certainly not the kidney at this stage that is causing this.
Right, sir. Sir, you saw this question earlier also from Dr. Sunitha from Chennai. I want to check whether CME credit points are available for this webinar.
We don't have those. Because webinars are now becoming so common, and because in the Corona era, we're not going to meet so frequently in real life, we're going to try and devise something. I don't know whether it's going to be done by the Radiology Association, by the Medical Council, but I think that gradually for webinars, we're going to apply for Medical Council points, and then we should manage those. But currently for this webinar, unfortunately, we don't have credit points.
Yeah. I think, sir, in the interest of the time,
Yes.
we will end here. There are so many very positive feedbacks about the session, and probably lot of queries about AI in ultrasound also. So about the clinical, thank you, sir. So about the clinical questions, sir, I will compile the rest questions and we'll try to reply through you, the participants.
We'll do that on email.
Thank you, sir.
Arnab. Thank you for a wonderful evening, and thank you, attendees, for being here. A pleasure indeed.
Thank you, sir.
Thank you, sir.
everyone.
Thank you.